and letting people in now.
Okay.
Men han må jo til Karlstad.
Just you want me to start, Joe?
Yeah, whenever you're ready, Mark.
Okay, rightio.
Thanks.
Hello, it's good evening from Australia. I'm sure it's at various time zones across Europe, particularly in the UK. It's my pleasure to be introducing Dr. Laura Ross and Dr. Julie McDonald tonight in Australian time. But welcome. I'm Mark Bowie. I'm one of the executives of the International Collaborative for Best Care for the Dying Person. And being an international collaborative, I'm centred here in Melbourne, Australia at St Vincent's Hospital and the University of Melbourne. As I said, it's a great pleasure, and I'll introduce our two speakers, or our speaker and our discussant, in a minute or two. So really just to again acknowledge that this is a presentation of the International Collaborative for Best Care for the Dying Person, and also in conjunction with the EAPC task force, the newly established link for care for the dying. Tonight, the focus will be on an illness that some of you may not have had a great dealing with, but it will be a discussion that will certainly be of revelation and importance for those of us who are working with the more chronically ill, non-malignant areas of care, which we'll come to. Now, why isn't that forwarding? This is always the case. You hit something and it doesn't forward. So let me just... Okay, next. Okay. Just very quickly, people may be already very aware after EAPC about the International Collaborative. We have over 900 members representing 6 different continents across the globe. And there's certainly a very a vision of where we hope that in the world where people experience a good death as part of the integral part of their individual lives, supported by the very best care. I'm sure it's something that we all would condone. At the heart of this is best care for the dying person. As you know, there's the quality improvement program known as the 10-40 model, but it's also supported by ongoing research, significant research, and education and training. And this webinar is part of that education and training process. As I mentioned, we are also part of the EAP task force on care of the dying, and it's certainly been in the last few months where we've become more involved, and certainly at EAPC this year we've had a number of connections with the task force in beginning the process of writing the white paper, which will be a pivotal event for care for the dying in EAPC. So you can see there how we're sort of linking and joining together. So tonight, as I mentioned, we have Dr. Julie McDonald, who is a colleague I work with through the Melbourne University and also at St Vincent's Hospital, Melbourne. She's a respiratory physician and then dual trained as a palliative care physician, and she's particularly focused on care of those with respiratory, cardiac, and now looking and focusing on scleroderma, which we'll hear about today. Dr. Laura Ross is also a rheumatologist, and she also has an interest in a number of areas of rheumatology, but particularly relevant to scleroderma and its impact and the chronicity of the illness issues that are presented. She'll be the discussant. So Julie will speak for about 40 minutes, and then we'll have a discussion led by Laura after that. If you do have questions, please put them into the chat function and I'll relay them to Laura as the talk goes on. So thank you, Julie. I'll stop sharing my screen and allow you to pop the slides up.
We're coming. It's just being a bit slow. There we go. All right. So thanks for the introduction, Mark. I'm going to talk today about can dying with scleroderma be dignified? So this talk is going to overview what scleroderma is, what the symptom burden is in scleroderma, how might early integrated palliative care help with scleroderma, and what we should be aware of when providing end-of-life care, and also to explore whether there's an association between voluntary assisted dying and scleroderma. So what is scleroderma? Well, it's also known as systemic sclerosis, and it's a multi-system immune-mediated rheumatic disease, which is characterized by fibrosis of the skin and internal organs, widespread vasculopathy, and a normal inflammatory response. It's an uncommon disease, and organ involvement and damage occurs from the outset and then is often irreversible, leading to persistent symptom burdens, impaired physical ability, and an impact on the physical, emotional, and health-related quality of life of the patient and the caregiver. Unfortunately, despite advances in clinical management, there's still an absence of truly disease-modifying therapies for scleroderma. There's no randomized controlled trials which have managed to positively impact on either symptom burden or quality of life. And patients with scleroderma still have the highest mortality of any rheumatic disease, with approximately a life expectancy of 1 to 3 decades less than the usual population. Scleroderma is broken into two main disease subtypes, which represents the extent of the skin involvement only. The most common subtype is limited, where the skin hardening affects the hands, and although internal organ involvement can occur, it's often over many years later of the condition. Diffuse scleroderma can affect the skin on the hands, the forearms, the upper arms, the trunk, and the thighs. And patients with diffuse scleroderma often have a more systemic condition with other organs involved, and they can require more extensive treatment. So the fibrosis, the vasculopathy, and the inflammation all have a profound effect on the organs and cause a real wide range of symptoms, which I'll run through for you to help understand the complexity of the disease. Raynaud's attacks are almost universal, and skin fibrosis causes itch, pain, and large and small joint contractures, which limit the function of the hands and arms. Calcinosis and digital ulceration can cause painful wounds with the risk of local and systemic infection, osteomyelitis, gangrene, and even autoamputation. Fatigue is very common alongside myalgia and a painful inflammatory arthritis. Dysmotility and inflammation of the gastrointestinal tract is really prevalent and causes high amount of burdensome symptoms. There's esophageal dysfunction, which can lead to symptoms of reflux, dysphagia, regurgitation, and vomiting, while gastroparesis of the stomach can lead to early satiety, abdominal pain, bloating, and distension. Gastroantral vascular ectasia, or GAVE, can cause chronic blood loss and lead to symptomatic anemia. Intestinal stasis of the small bowel can lead to overgrowth of bacteria called SIBO, while dilation of the intestines in the large and small bowel can cause pseudo-obstruction, as an obstruction without mechanical obstruction. And all of these intestinal symptoms can cause pain, bloating, constipation, diarrhea, incontinence, malabsorption, and malnutrition. Malnutrition can also be worsened by skin fibrosis around the mouth, which limits mouth opening, and the presence of sicca symptoms or dry mouth, which can lead to dental caries and oropharyngeal dysphagia. Cardiopulmonary disease is both common and complex and is the leading cause of mortality. Interstitial lung disease, pulmonary hypertension, cardiac fibrosis, and skeletal muscle involvement can all cause interrelated symptoms of breathlessness and decreased exercise tolerance. Cardiac involvement can cause right or left heart failure, palpitations, pre-syncope or syncope, and persistent cough can be caused by interstitial lung disease and be exacerbated by reflux, vomiting, aspiration, or infection. Scleroderma has a significant impact on the mental, emotional health of the person. Depression and anxiety are common, as are emotional distress, social anxiety, social avoidance, body image distress, low self-esteem, decreased concentration, and sexual dysfunction. In addition to all these symptoms, patients with scleroderma face a shortened life expectancy with all the social and existential distress this holds. And this is particularly true for people with pulmonary hypertension and interstitial lung disease. The impact of scleroderma also extends to the family, as patients require significant emotional, physical, and informational support throughout what is often a prolonged caregiving role. So all these physical, social, and emotional impacts already paint a picture for the potential need for palliative care. But how prevalent might that need be? Well, we've quantified the potential need for palliative care based on a retrospective evaluation of the symptom burden of 875 patients in this Australia scleroderma cohort study. Patients completed PROMs, or patient-reported outcome measures, yearly, and specialist palliative care needs was defined as a high symptom burden at 2 or more appointments or 1 appointment prior to death. And the results revealed almost 3/4 of patients met the threshold for requiring specialist palliative care based on symptom needs alone. Severe fatigue was most common, followed by breathlessness and severe constipation, but concurrent severe symptoms were frequently observed, as you can see with the overlapping circles there. These symptoms are all associated with a significant effect on the quality of life and function of patients. So we thought, does 75% of people needing palliative care for symptom burden? We wondered really whether it could truly be that high. So we invited consecutive scleroderma patients attending a specialist clinic over 12 months to prospectively complete a symptom assessment score, which you might know well as the ESAS, or Edmonton Symptom Assessment Score. Now, this is a very simple one-page 0 to 10 assessment of general symptoms, and the score is most widely validated in oncology and is being considered as a tool for triggering palliative care referral. Now, this is unpublished data, but to date, 165 patients responses have been received, and using severity scores validated in oncology to trigger referral to palliative care, ESAS analysis suggested 65% of scleroderma patients would benefit for referral for symptom management, which is similar to that of advanced cancer. And as you can imagine, in advanced cancer, patients also do have quite a mixture of symptoms due to cancer affecting multiple organs. But you can see here the pattern of symptoms is actually quite different to advanced cancer, with nausea and breathlessness predominating, though the overall prevalence of severe symptoms is actually the same. So what we can see from this data to date is there is actually probably a pretty high need for attention to symptom management in scleroderma, and we could consider a palliative care approach to help the management of that symptoms. But we need to figure out if palliative care can really help with symptoms in scleroderma and not just extrapolate outcomes seen in advanced cancer. It is, of course, also important to realise and remember, of course, that palliative care is not just symptom management alone. So we know that most people think palliative care is synonymous with end-of-life care, but increasingly early integrated care is being recommended. Early integrated palliative care is now recommended in advanced cancer as standard of care, but also international guidelines such as the American Heart Association and American Thoracic Society are now recommending early integrated palliative care for conditions like heart failure and advanced lung disease such as interstitial lung disease. And what this means is delivering palliative care early, sometimes from diagnosis and then throughout the course of the illness, rather than only referring at the end of life. Integrating palliative care into routine care means providing symptom management, psychosocial support, and high quality communication hand in hand with disease-orientated care. And if you integrate early palliative care, it's been shown to improve quality of life for both patients and their caregivers, improve satisfaction with care, improve mastery of symptoms, increase advanced care plan discussion and documentation, and a reduction in hospitalisation and cost savings. So given interstitial lung disease and cardiac disease are the leading cause of death in scleroderma, it's intuitive that early palliative care might also be recommended in scleroderma. But if we have a look at the most recent international 2025 EULAR recommendations for scleroderma, there's unfortunately no mention of palliative care at all. In fact, they explicitly mention that severe disease isn't included in their review, but they don't mention why. There's no mention of palliative care within the text, and not even a sniff of something like supportive care or holistic management. In their poor prognostic group, their only recommendation is for higher intensity treatment. So why is there no mention of palliative care? Well, I think they can't recommend something that has an absence of evidence, can they? And although that there is good evidence for palliative care in interstitial lung disease and heart failure, that evidence hasn't been translated from ILD to scleroderma-associated interstitial lung disease. And there's some potentially good reasons for that, because scleroderma ILD doesn't occur in isolation. It's part of a complex and multi-organ condition. These most recent published articles from 2024 and 25 show the potential role and need for research in palliative care and supportive care and a more holistic approach to care in scleroderma. But I have to declare a conflict of interest that 2 of the 3 papers are from our own institution. So what could palliative care offer in scleroderma? Well, we think the role could be similar to early palliative care in other malignant and non-malignant disease like heart failure and interstitial lung disease. There, the usual disease-orientated management is provided hand in hand with palliative care tasks. In scleroderma, we've described this as providing information and education about the illness, to provide collaborative and multidisciplinary care, to consider rheumatological disease-orientated management for symptom control alongside non-pharmacological and pharmacological symptom management, helping with assessment and referral for practical supports, equipment and connection to resources, providing psychological and spiritual support, helping people manage the uncertainty of the disease and the illness, and also living well with their serious illness, and providing serious illness communication, which means assessing preferences for information and then sharing in accordance with those preferences, information about the seriousness of their disease, their prognosis, assessing values and wishes in advanced care planning discussions, signing advanced care planning documents, medical power of attorneys, and eventually planning for and providing end-of-life care. So given the complexity of symptoms in scleroderma, the complexity of the illness in scleroderma, and the lack of evidence of palliative care in scleroderma, we decided to start with a world first trial of early integrated palliative care. And we introduced this in a specialist centre at St. Vincent's, which delivers care to a high number of people with scleroderma. We nested the clinic within specialist rheumatology scleroderma clinic to ensure we had a close collaboration with rheumatologists, a unified approach to care, and we could drop the appointment burden for all our rural and regional patients. We used triggers for referral to palliative care based on interstitial lung disease and heart failure, where a high symptom burden of symptoms such as breathlessness with activities of daily living or frequent hospital admissions could trigger referral, as well as decreased function or increased reliance of family caregivers, or anybody who is being considered for a lung transplant or autologous stem cell transplant for scleroderma, or anyone with a perceived poor prognosis using the surprise question, would you be surprised if the patient died within the next 12 months? Between July 2023 and 24 patients received 52 clinic reviews. 63% were face-to-face, 29% were by phone, and 8% by telehealth. 20 patients identified a caregiver, and caregivers attended 42% of the reviews. The median age of the patients seen was 67, but a wide range between 19 and 87 years, with 71% being female sex. 54% of the patients had diffuse scleroderma, and the median time since diagnosis was 9.5 years, but again a wide range from 0 to 40 years. Functions was described by the Australian Modified Karnofsky Performance Scale with a median of 60 as able to care for most needs, but requiring occasional assistance. So what did we do in the clinic? Well, the palliative care tasks were actually offered to patients and families, and they decided what elements they wanted to engage with. The great majority were provided with psychological support, and they all had their social supports assessed. 46% were referred on for formal aged care or disability support. 25% of patients were seen on the same day as rheumatology, but even outside those appointments, 83% of patients had a lot of informal multidisciplinary discussion, which often occurred within the clinic appointment and highlighted the importance of being on-site with Scleroderma team. Despite there being a really early introduction to palliative care, actually a lot of patients, or most patients and family, took the opportunity to talk about the seriousness of their illness. And these tasks were broken apart in serious illness communication, with some people being quite clear they didn't want to talk about prognosis, but were happy to engage in advanced care planning or sign a medical power of attorney, showing it wasn't a one-size-fits-all approach. In summary, the high prevalence of tasks taken up here highlighted both the potential unmet need and acceptability of these tasks. In fact, I think there's definite potential for some of this care to be delivered to more people and earlier. For example, by a nurse or a social worker with knowledge about specialist scleroderma. They would be ideally suited to provide education and advice on non-pharmacological symptom management, as well as psychological support and begin advanced care planning discussions. But to focus on a minute longer on the specialist palliative care management we provided, we can see the high prevalence and the change in disease-directed management and the high prevalence of pharmacological symptom management, and also symptom-specific action plans like breathlessness action plans show how in-depth the knowledge of scleroderma has to be to provide palliative care in this space. And to explore this further, I want to show you two case studies from the first year. The first was a gentleman in his 40s who was referred to me for fatigue management and psychosocial support. And there was about a 2-month wait between the rheumatology review and my first review. At my first assessment, I did find him to be fatigued and have significant insomnia as well as suicidal ideation, but he also had rapidly progressive skin disease. His skin was tense and inflamed and almost bubbling from his arms to his trunk. He'd also developed rapid onset of large joint contractures in the elbows and shoulders. He also had 20 episodes of diarrhea a day, which he was managing with 20 showers a day because he wasn't able to move his elbows and shoulders enough to attend to his personal care. My management was that of rheumatological discussion, who arranged rituximab within 2 weeks, as well as discussing with him exercise, sleep, smoking cessation, skin care, antibiotics for his diarrhea, and allied health referral. And after a few months, I should say, he had significantly improved disease control, a positive mindset, and the allied health team had arranged a bidet for toilet hygiene, a birth certificate, which allowed him to apply for a disability allowance. Now, none of this was pharmacological symptom management, of course, but it does highlight that you need expert knowledge and collaboration with rheumatology and allied health teams to get quality of life improved for some patients. This is his skin here. I hope this projects well, but you can see in his upper arm, it's almost sort of dry scarring, like burnt scarring, whereas in the lower arms, his skin's bubbling with the active disease. It was very tense and painful. The second gentleman was in his 70s and was referred for future care discussion and social supports. And on my first assessment, I found him to be breathless and having breathlessness with panic. He had uncontrolled right heart failure, a low function, spending more than 50% of the time resting in bed, and no formal supports, as well as very strained family caregiver supports. We managed him with arranging aged care referral for in-home supports of 4 hours a day, managed a right heart failure action plan to get his fluid under control. We up-titrated his oxygen and provided a breathlessness action plan as well as some morphine, advanced care planning discussion and advanced care directive completion, a discussion of his end-of-life care preferences, and referred him to community palliative care. Over the next several months, we had close phone calls between him, his caregiver, and the community palliative care team, as well as the rheumatology team, in which we encouraged the continued use of pulmonary hypertension meds and furosemide till the end. We utilised SIBO-related antibiotics for his diarrhea rather than the antidiarrheals they were trying to, but unsuccessfully using. And he managed to die at home, which was his wish. To consider more the further role of needing expert scleroderma knowledge when providing symptom management, I wanted to consider me seeing a patient with scleroderma who's become more breathless. I have to think, is this their pulmonary hypertension progressing or interstitial lung progressing? And do they need medication titration? Is the oxygen too low? Does that need review? Or are they in right heart failure and do they need an action plan? When I think about the goal of each of the management treatments, I think, is this here for symptom management, such as buscopan for cramps, or to try and prevent complications, such as an ACE inhibitor might decrease the risk of renal crisis? Is the med for slowing lung disease progression, like nintedanib, or is it a combination of all these with proton pump inhibitors, which can decrease reflux, as well as decrease Barrett's and the risk of esophageal cancer, as well as decrease the risk of interstitial lung disease? Non-pharmacological approach for symptom management knowledge has to be quite broad. You have to know everything from Raynaud's management to the use of high protein but not high fat diet for loss of weight, as high fat can exacerbate diarrhea. You have to know about skin care for pruritus and breathlessness action plans for breathlessness, and exercise for fatigue management, which is the best and most evidence-based treatment for fatigue. If I use pharmacological symptom approach, my approach is to start low and go slow. There's chronicity in these symptoms. It's not the acuity of malignant symptoms. You have to move slowly with the meds. If you go up too fast, you'll get adverse drug reactions and the patient will lose faith. And adverse drug reactions are so common in scleroderma. For pain, we think, but we don't know, that tramadol, tapentadol, and oxycodone seem to be better tolerated than high doses of morphine, which tends to cause adverse drug gut reactions. But for breathlessness, we can get away with tiny baby doses of liquid morphine, such as 0.25 or 0.5 milligrams as part of a breathlessness action plan. And what I also find is often it's a lot of low dose drugs rather than one high dose drug that is both tolerated and successful for symptom management. To explain how complex symptom management can be, I want to show you one case study of a lady in her 60s with diffuse scleroderma who was referred for symptom management. She had dry eyes and mouth, Raynaud's, active skin disease with itch and pain, upper and lower GIT dysmotility. She just had a hospital admission with aspiration pneumonia because her patulous esophagus has dysmotility, and so she was refluxing and vomiting, causing pneumonia. But she also had low mood, insomnia, and fatigue. Now, this is her scleroderma medications list after a year and a half of scleroderma palliative care reviews. This isn't actually her entire medication list, just those only relevant to scleroderma. And I don't want to either bore or overwhelm you here, but I do want to highlight how many medications were needed and highlight that this is quite typical of a scleroderma medication list. We often need to use many drugs at lowest doses rather than one high dose. And many of these drugs are for multiple symptoms. I also want to highlight at the bottom all the adverse drug events and ineffective meds that we did try but weren't tolerated. So we try and keep a close list of those too. In addition to all these meds, we also provided a lot of non-pharmacological management, action plans, allied health referrals, and we completed future care discussions, advanced care directives, and referred her for my aged care support, which managed to get her 4 hours of in-home care per day in Australia, which is the maximum support package. And here's some notes from my most recent review showing that the rituximab was managing her skin and contractures, but she was still getting quite a lot of pruritus in her skin just prior to each rituximab dose, which we managed with a gabapentin action plan. Exercise in rituximab was allowing her skin to relax. It was improving her posture and exercise tolerance. Her nausea had improved and she started to move her Maxilon to only PRN, and she'd gained 5 kilograms of weight. Her diarrhea was ongoing but actually tolerable, and her mood, insomnia had both improved with support, exercise, and medications. But what about more than anecdotes though? Well, we've conducted semi-structured phone interviews with patients and caregivers who attended the clinic in the first 6 months to explore whether they found the clinic acceptable, valued, and whether there were any gaps or barriers to care. we used a reflexive thematic approach to guide data collection and data analysis. This is unpublished, but 6 patient, 3 caregiver and 3 caregiver patient dyad interviews were performed, and 2 major themes emerged across the data. The first was that of living with and caring for scleroderma, where people described the profound daily impact of living with scleroderma on their lives and highlighted both their gratitude of and burden of caregiving. The second theme was that of the experience of the palliative care clinic, where 4 sub-themes highlighted the respectful communication of the physician and how it was appreciated, the valued integrated structure of the clinic, the dichotomy of receiving palliative care, which explained both relief and hope from symptom management with the risk of distress from the term palliative care, as well as the divergence and acceptance of future care discussions, where strong preferences either for or against these discussions emerged. And a few quotes highlighted these themes. One patient said, "The physician has got me to a place where I am at now. Despite being very sick, I'm at a good place, so I figure it must be working." Another said, "The reviews actually give me confidence, if you like, because you always think there's another solution." Another said, "From my first introduction to the physician, I pretty much organised everything. I wouldn't be where I am now if I hadn't had those conversations with them." Another said, "The physician was gentle with the responses, not brutal in the delivery. We need to know the truth, but the delivery is also important." And the last highlighted, "When someone says I'm with palliative care, you can imagine how upsetting that is. But the physician was very encouraging to me. I was very low, so it was a very positive experience for me. I actually really felt like I could get some support." These results help demonstrate that early integrated palliative care is feasible and well received, but also highlights the importance of delivering palliative care in a sensitive and person-centered way can help foster hope and optimism, both about symptom management and the patient's futures. So I want to park early palliative care then and gear shift now to talk more about end-of-life care in scleroderma, where the principles of symptom management are actually quite starkly contrasted to that of early integrated palliative care. So why is recognising dying important? Well, we know, of course, it allows a shift in goals of care, which helps us employ high quality end-of-life care. It avoids futile treatments that might prolong suffering and be expensive. It allows effective symptom management. It helps manage the expectations of patients and families and helps make decisions in line with their values and wishes. It allows us to provide good psychosocial support and to the patient and family and can improve the quality of life in the final days and hours. So how do we recognise dying in scleroderma? Well, the trajectory is probably more like the non-malignant orange line here rather than a malignancy line. And it shows a background of slow deterioration, but also acute but often reversible declines. And that's very similar to something like chronic obstructive pulmonary disease. Now, it's not often easy to recognise dying, as those acute deteriorations can be reversible. And so often we try and ask ourselves, is there accelerating progression? Is that background trajectory speeding up? Is there a reversible cause for the deterioration seen? And would I be surprised? Would I be surprised if the patient died this admission, in the next 6 months, or in the next 6 years? I wonder whether you think rheumatology should be better at recognising dying in scleroderma. Well, it's actually not that easy to do if you don't see very much of it. And at St Vincent's, which is one of Australia's largest scleroderma providers, we actually only see 1 to 4 patients die a year of scleroderma. So it's not that easy when it's a rare condition. What about the available evidence to guide us in how we manage dying? Well, what we do know is that most patients die of cardiopulmonary complications of scleroderma, but actually any evidence about what they die of or how they die, is actually back from the time when everybody used to die of renal crisis. There's actually nothing now describing what end of life care looks like in scleroderma. And so we've commenced a small retrospective audit of all the deaths at St Vincent's over the last 10 years, which equals 33 patients. The aim of this was to try and evaluate the symptoms and the pharmacological management of scleroderma patients at the end of life in a tertiary setting. And what we found is the most common symptoms were that of breathlessness and pain. We also found there was a very short median duration of the terminal phase, defined as the time between commencement of end-of-life care and death. It was only 1 day. And 1/3 of patients suffered from agitation or terminal restlessness, which rapidly escalated in the last 48 hours of life. Now, reflecting that rapid increase in symptoms at that last 48 hours is also the dose of opioids that were given in the last 48 hours. The oral median morphine equivalent dose was only 3.9 milligrams at 48 hours prior to death, but it increased to a whopping 60 milligrams on the day of death. And this difference between the morphine dose is actually visible depending on the site of care, with palliative care unit doses being higher than the acute hospital setting, which potentially shows the readiness or the comfort of the increased use of opioids at the end of life. Similarly, benzodiazepine use escalated in the last 48 hours of life, with only 5 patients using benzos 48 hours prior to death, but they're increasing to 22 patients on the day of death. However, that use was entirely limited to patients in the palliative care unit, with no benzodiazepine use in the end-of-life care in the acute hospital setting. In summary, breathlessness, pain, and agitation are commonly observed at the end of life in scleroderma patients. The terminal phase is short, or recognizing dying is very late. There's often a rapid increase in symptoms in the last 2 days of life and needing a rapid up-titration of medications to manage that symptoms. So I want to touch on 2 cases which demonstrate the potential issues we can face at end of life. The first lady was in her 60s and had been in hospital for more than 4 weeks with pseudo-obstruction and functional decline. Her deteriorating phase was recognised on a Friday afternoon where a low-dose syringe driver was started because she'd only used minimal PRNs. The patient actually called it. She said, "Today's the day," and later started asking if she was dying. I want you to note all the adverse drug reactions on her chart, highlighting the tumultuous journey that's pretty common in scleroderma with meds and the adverse drug reactions. Unfortunately, she deteriorated to dying overnight. No care plan for the dying person was commenced, so it's a bit hard to quantify what her symptom control was, but a whopping 16 PRNs of oxycodone and 8 PRNs of midazolam were administered before there was a large increase in her syringe driver and PRNs were escalated and re-prescribed. She was more comfortable by her death a few hours later, but that rapid increase in PRN usage is pretty typical for that rapid increase we see in other cases of scleroderma at the end of life. Now, in contrast, another lady in her 60s had had a 2-month admission, though the first month was in the acute setting and the second was in the palliative care unit. Breathlessness was her main issue. There was ongoing liaison between rheumatology, specialist scleroderma palliative care, and palliative care, in which we continued to advocate for ongoing management of her pulmonary hypertension and heart failure to help her manage symptoms of breathlessness. We also used high flow nasal prongs at 50% and 45 liters with intermittent daily OBS to try and check that she was between 88 and 92% to ensure that hypoxia wasn't contributing to her breathlessness. This day, she was commenced on quite a robust syringe driver, despite her anxiety, which was navigated around previous use of syringe drivers and a previous slow-release opioids, which again reflects her lifetime of adverse drug reactions. Now, despite the team thinking that dying wasn't imminent, they were ready with her PRNs, and the patient had a sudden but comfortable death that night. The care plan for the dying person used here highlights that comfort in the terminal phase. So both these cases to me highlight a short terminal phase, a rapid need for increase in medications, and both were after quite a long hospital admission. They both highlight the opposite message to that of early palliative care, which was start low and go slow. At the end of life, we need to be ready to move fast with meds, ready to increase them fast and call for help. We need to consider ongoing active meds till people can't swallow, and consider things like oxygen for breathlessness and care plan for the dying person to ensure that best care happens no matter the site of care. Also want to highlight the recognition of dying as a medical emergency if there is distress. So one last change of gears to voluntary assisted dying and scleroderma to consider just briefly if we think there might be a relationship here. So Voluntary Assisted Dying Act was actually enacted in Australia and Victoria in June 2019, and since then has been a valid, available option for end-of-life care. It allows people to access VAD who've been diagnosed with an advanced, progressive, incurable condition with a prognosis of less than 6 months, where the condition is causing suffering that can't be relieved in a manner that the person considers tolerable. The VAD Act allows people to take a lethal substance that at the time of their choosing to end their life. Now, access to VAD was considered essential by a scleroderma patient who was very active in her advocation for VAD in 2017. However, it's unknown whether VAD is actually a widely desired treatment option for patients with scleroderma. Early results from our 12-month audit of our scleroderma palliative care clinic showed 17% of patients raised voluntary assisted dying. A quick look back at our St. Vincent's data from 2019 to 2023 agrees that scleroderma does appear overrepresented, with up to 7% of people who are requesting information about VAD coming from people who are living with scleroderma. While this proportion might seem high, there's actually no statewide, national or international data available to quantify if scleroderma is overrepresented as a health condition. We're actually undertaking a mixed method study to understand why people living with scleroderma might choose to explore VAD as a treatment option and what their current and future met and unmet needs are that they have to allow to maintain their health and well-being while living with scleroderma. The study will hopefully inform us if there's any challenges in accessing VAD and inform future policy to ensure VAD policies meet the needs of those living with scleroderma. It will also help us to fully understand the end-of-life care needs of people living with scleroderma. So what is still unknown about living and dying with scleroderma? Well, a whole lot, unfortunately. There's still really minimal evidence to guide symptom management throughout the journey of scleroderma. At the moment, what we have is mostly siloed advice from each organ specialist, but not a holistic approach that incorporates non-pharmacological, pharmacological, and disease-orientated management all hand in hand. Once we understand this, I think it's going to be really important to share this information in peer-reviewed journals for healthcare professionals, but also in patient information brochures, because it's really hard for patients to find symptom management advice. We have data collection underway of a 3-year review of our scleroderma palliative care clinic to understand if palliative care could impact on acute hospitalisation and cost, whether it could impact site of dying or quality of dying. But we need a lot more studies to understand if there's an improvement in symptom management or an impact on quality of life. And we still don't understand the experience of living with and caring for scleroderma. Early palliative care interviews that we have with patients, caregivers and healthcare professionals highlight that although patients' medical needs might be met, the social and emotional needs probably aren't being met. So how do we provide integrated palliative care to more people and earlier, and consider the use of scleroderma trained nurses or social work to allow an increased access to allied health care to provide a more holistic approach to patients? So in conclusion, I'd like you to make room for palliative care and scleroderma, a condition with high unmet needs, where the initial outcomes of early palliative care have been found to be acceptable and valued. And if it's delivered in a sensitive and person-centered way, it can improve hope and optimism. We need to consider the longer-term impacts of palliative care, how we can provide it to more people and earlier. And we need to consider that dying with scleroderma might have a long deteriorating phase, a short but sharp terminal phase, which needs a lot of active management and active up-titration of palliative care meds. We also need to understand if VAD requests are overrepresented and why. I think all this information will allow us to better advocate for the development of guidelines that incorporate palliative care into routine scleroderma care. So in summary, I hope this presentation has convinced you that we need a strong evidence base to ensure that we provide death with dignity in scleroderma.
Great.
Thank you.
Look, thank you, Julie. That was an extremely comprehensive taste of the journey that the scleroderma patients need to go on, but also the clinicians that are supporting people with scleroderma to be aware of. So thank you. We're going to bring Laura in now. I think I can see her on the screen. And Laura, as discussed, and again, Laura is a rheumatologist who is intimately involved. And in the next 10 minutes, we will get Laura to have a conversation with Julie. I'm just trying to see where she is at the moment.
I'm here, Mark. I just am not able to turn on my video, but I've been able to turn on my audio, so I can.
Great, thank you.
Some questions if you're ready.
Yeah.
Great. Oh, let me turn my video on. Perfect. Great.
Great.
Thanks very
Thank you,
much.
Laura.
Great. Thanks very much for having us here this evening and giving us the opportunity to talk about scleroderma. And thank you, Julie, for that wonderful presentation. I was just interested in your thoughts because whenever I speak about palliative care as a rheumatologist, it often raises a lot of questions. Rheumatology and palliative care are not necessarily seen as specialties that are natural bedfellows, and that's why would a rheumatologist have access to palliative care? And I think we've observed in scleroderma, and we see it in a lot of other systemic autoimmune diseases, that our patients have a quite rapid onset of really significant internal organ involvement from their disease at a very young age, face years of a number of lines of quite aggressive treatment with the hope of their rheumatologist continuing aggressive lines of therapy to try and preserve and hopefully regain organ function. But this is coupled with a significant symptom burden faced by patients, in the case of, say, lupus, for example, often, young women in their early 20s. And to my mind, there are, I guess, a number of potential barriers to being able to access high quality symptom-based care or holistic palliative care. And I was just wondering if you had any thoughts about, I guess, this sort of idea of introducing palliative care very early in the course of diseases that mainly affect young people, and also in diseases that people live with for a very long time, and who, people who are facing or looking at decades and decades of treatment. So perhaps have a treating physician that thinks that palliative care might be something for, when they reach their 70s rather than when they're 27.
Yeah, I mean, it's a good point. And it is something that we've been through the same sort of journey with a lot of other non-malignant diseases, such as heart failure and interstitial lung disease, or Parkinson's disease, as you know, motor neuron disease. So I think a few things. First of all, the palliative care we provide in non-malignant palliative care and non-malignant illnesses is actually quite different in a way to the providing palliative care at the end of life. So it really is that symptom management, but hand in hand with the disease management. And there's a lot of psychosocial support, because people really do reel when they're diagnosed with a potentially chronic and life-limiting illness, and having someone help them navigate that uncertainty and distress can be really helpful. Does it need to be a palliative care physician? Well, I think not, but it does need to be someone who has enough time and skill set. So, I mean, wow, it'd be wonderful if you could do it all in your clinic, Laura, and other rheumatologists could, but they'd have to be both trained and have time. And I think, comparing your clinic list to mine, I see a lot fewer patients in a half day than you do. I also think that when introducing early palliative care to either physicians or patients and their caregivers, when it's early palliative care, it's important to try and describe the tasks first. as one of the professors we work with, Prof. Jenny Phillip, is in the progress of publishing, she thinks one of the hardest communication tasks is breaking the news that someone should see palliative care. And so she recommends that describing the tasks first, as in to say, I can see you having a lot of trouble with a lot of symptoms. I actually have a colleague who's really good at symptom management. I wonder if it would be helpful to see someone like that. And if you get agreement, then explain that that person is palliative care, but that you're not referring for end of life, but for symptom management. I hope that helps answer, because it is a really complex journey, isn't it?
Yeah, and I think that leads into, I guess, another comment, something I've observed in sort of often referring patients to palliative care, I guess, from the other side. You made a comment about in one of your cases about a patient with pulmonary arterial hypertension and heart failure remaining on those medications, those so-called active treatments, right up until the end of life. And so I guess patients receiving ongoing and quite aggressive medical management, and then referral to palliative care providers, and then some sort of almost a hesitancy to say, well, the patient is still receiving active treatment. What is the role for palliative care here? And I was just interested in your thoughts on that, sort of looking at that same issue from the other perspective.
Yeah, and another issue again is if a palliative care team has little or no experience with scleroderma, one of our main tasks in palliative care is deprescribing. So it's really important for people providing palliative care to understand that those scleroderma meds are there for symptom management. A whole bunch of them are there. So I think what that highlights really is the importance between collaboration and a multidisciplinary approach to care. And that care can't be siloed. It has to be a discussion between the teams. You know, as our clinic showed, 83% of patients were discussed sort of on site because we have to do it together. I think you could get into trouble if you didn't, if you provided siloed care. I think that would be my main thoughts.
Yeah. And I was just wondering maybe if you could, I guess, just describe how like the integrated model works at St. Vincent's, I guess just on a day-to-day basis, and what you think have been the major benefits that you've observed, both from a palliative care perspective and potentially also from the other teams that are involved, from having a model that is designed in that way.
Yeah, so at St. Vincent's, the early integrated scleroderma palliative care clinic is a twice a month clinic, which is embedded within the weekly scleroderma clinic. So I'm not there every week. There's not quite the need or demand for me to be there every week. But on site in that clinic, of course, the treating rheumatologists. But actually, at the same time, there's also cardiologists who aren't necessarily there to see scleroderma patients, but can do. And then upstairs at the same time is gastroenterology. So often for a complex multi-organ patients who are rural and regional, they can actually come down and have all their scans and reviews done within 1 to 2 days, which is really important. And the other thing is that because we're all on site together, it does help with just that informal multidisciplinary discussion. But in addition to that, we actually have a monthly formal multidisciplinary team discussion where we're all there. And that discussion is actually really helpful for everybody to learn from, because of course, palliative care upskill from understanding all the treatment management and investigations needed in scleroderma, but also I think we all benefit from considering a more holistic or sometimes patient-focused approach to patients by being able to discuss it all together with all our hats on. Yeah, so I think it's been really helpful.
And I guess just briefly, we're sort of nearing the end of our session. I was just wondering if there were any other questions from the audience. If anyone else wanted to ask a question.
I haven't seen any come up on the chat, but if anyone's got any particular comments, please quickly pop them in the chat room. I guess somebody I can certainly say, obviously being involved at the other end, and certainly involved obviously in the whole process of evolving the early integration process, and obviously watching Julie and Laura and others in that space. Certainly when it does come to end-of-life care, just reiterating that fact that we continue to link back to those that understand scleroderma, and again, the careful titration when we're not recognising dying continues, but then realising that we need to escalate very quickly. And I think we have had very successful, I would say, psychological well-being in the attainment of dying, even though some of them are exploring a VAD at the same time, but ultimately have felt safe and sort of wrapped around, I think, by the care of the palliative care unit, where their anxieties have really diminished. So even though they might explore VAD, it so far hasn't been something that has always eventuated.
That's right. I can see Janelle's question there, though I can't just open the chat to see it fully. Oh, she's asked about is there
how many people have used
patients?
voluntary
Yeah, we
dying?
actually don't have any information on how many patients with scleroderma have completed death with VAD, but that's part of the question that we'll be asking over the next 2 years, because it does appear that scleroderma is overrepresented. And it could be that not many are actually accessing it, and it could be that there's some trouble with accessing voluntary assisted dying, perhaps because it's difficult to prognosticate, or perhaps it's because a lot of people ask about VAD and then don't need VAD. It's really hard for us to know, but it does definitely look like there is an association between those two. Yeah.
There's also a comment from Tara, and you may know Tara from Scleroderma Australia, or she's talking about maybe patient resources as well that could be utilised in
Absolutely.
Sort of
I should highlight that. Yeah, Scleroderma Australia has some great patient information brochures about scleroderma, and it does also touch on the non-pharmacological symptom management of scleroderma.
Right.
Yeah. I think the last thing I'd say to highlight just briefly is that we know everybody can't replicate this model of early integrated palliative care, but I think there's some really important points which everybody can utilise. So hopefully that's been helpful.
Yeah, look, thank you, Julie, and thank you, Laura, for being part of this. I'm just going to share my screen again. We've just got just a few concluding slides with regards to, oh, I'm just opening the wrong one at the moment. It's not even useful. But really to highlight that again, thank you again for the quality of the presentation, and I'm just popping this up. But really just to say that these webinars run 4 times a year, and at the moment, the next one, which is being held in the date is there in the 11th of September, is actually looking at the development of an international biobank for research in palliative care, and some of those names will certainly be familiar to people, with Leah from the Netherlands and Juan Jose, but Seamus Coyle from University of Liverpool as well. So please put that in the diary, and that should be an excellent presentation. And really just to remember, there's the annual conference, international conference is going to be in Liverpool this year towards the end of November. Abstracts are still open, so if anyone wants to put abstracts in, they're still available until next week or later next week. And really just to highlight that our annual symposium, our annual summer school, which is actually should be 26th rather than 25th, is being held in the 2 days early part of the week prior to EAPC in Prague. And that's held in Malaga. And that's really a time where clinicians can come together and really look at caring for the dying person and the plans that are available, and to really sort of look at the quality improvement processes that can be brought to bear on any illness area that is related to palliative and end-of-life care. Okay, and for further information, please go to the website, or you can certainly scan the code that's on the screen at the moment. So really to say thank you to Joe, who's sitting in the background there, orchestrating and organising the webinar tonight, and to thank the participants. So thank you for joining us, and those who might be listening to this at a later date, but really to particularly thank Julie and to thank Laura for being part of the presentation tonight. So we'll wish you all a good rest of the day. Thank you.
Thank you.